Great, thank you, Brian. Lloyd and I are pleased to be here with everyone today and are eager to share what we've learned applying the science of improvement to the COVID-19 pandemic. And I will say that whenever Lloyd and I look at data, our default lens is always around asking two questions. The first is, what can we learn from the variation in the data? And the second, is the variation in a process, a system, or an outcome stable, or is it telling us that something has changed in really important ways? We've been applying this approach broadly to public health data for about the last decade and think there's incredible opportunity to apply the approach here relative to the pandemic. Today, we're going to be sharing an approach we're using to model COVID-19 deaths. We've had a team behind us that included Gareth Perry, Shannon Provost, and Kevin Little. And what you're going to see here reflects existing improvement concepts and knowledge, as well as the application of a new one. But before we get started and jump into that, I wanted to kick things off with a question just to get people engaged and thinking about the conversation that we want to have. On the slide right here, you can see that we are plotting the numbers of new deaths reported each day in country. And the question is a simple one. What do you see when you look at these charts? And if you could just type that in the chat function, and Brian, maybe you could help me hear what people are saying. We could just take 30 seconds to do that. Really interested in what people are seeing when they look at these two charts, country A and country B.
No problem, Rocco. Our first one from Ahmad, who's just said outlier.
Outlier.
Yeah, Stephen has said special cause. Ahmed has said sudden increase, few special cause variations, special cause. Yeah, plenty special cause coming through here. C chart stable until 314. Yeah.
Great. Wow. Whoever said it was a C chart, that's pretty good because it doesn't say it's a C chart. These are actually two C charts. We're looking at numbers and counts of reported deaths. And yeah, this wasn't a trick question. And clearly folks on the line understand the notion of special cause, which is fantastic. So what we can do here is, we can look at data like this and then ask the question, where did things go? What happened after that point in time? And if we fast forward to about 3 weeks or 21 days, we can see in both of these countries that they have the number of deaths have basically skyrocketed and have now entered into exponential growth. These two countries, I will reveal them. Country A is Germany and country B is the United Kingdom. This type of relationship between a first sign of special cause and exponential growth could be modeled in many countries, in the countries that we've looked at. But what's really fascinating is that if we identify that special cause on these on the charts to the right that are in exponential growth, we see that we get our first signal way back in time. The real interesting observation is that from the moment we hit that special cause on the C charts, on the control charts to the left, we never look back. Those countries begin exponential growth and they don't return and haven't returned to that number of deaths since, even though they've gone through a number of different evolutions over time. And with all the talk of flattening the curve, one of the things that we think is incredibly powerful is to have the ability to detect at the moment the curve begins to take its upward form. To do that around almost the exact day is powerful learning for us and for leaders across the globe that are having to look at this data and make really important choices around them. The challenge here unfortunately, is that we do not use these charts to look at this data as often and as regular as we see. We certainly haven't applied it in general to the COVID-19 deaths, which is one of the things that Lloyd, I, and the team are really eager to do. But it's actually worse than that. Not only do we not use these charts, but because we're not using these charts, we are not using a theory of variation to ground us in the actions that we need to make. And that's the real important point. What does this look like in practice? Well, on the next slide here, this is just a quick case study that if you don't have an underlying theory of variation guiding your work, every day becomes a new story every single day. We're looking here at New York, but I could very easily replace this with the Lombardy region in Italy or Wuhan, China. Every day is a new story, a reason to be panicking or a reason to be hopeful. And when we look at the blue dots, this is, again, the state of New York. Every one of those dots has multiple headlines, and they're thematic. So what we look on March 25th, what we see is one of the headlines, which I didn't put here, was that we are heading into an apocalypse, or that the death toll spikes 110% in 36 hours. And you can see that climbing all the way up until we get to the peak on April 2nd. New York virus deaths hit new high. And obviously the sense of concern, panic, and despair begins to set in. But then the next day, literally in less than 24 hours, the headline reveals that the death toll drops. And the governor of the state, Governor Cuomo, says the crisis could be plateauing based on one data point. People are hopeful. If you read the op-eds that get written, almost immediately you begin to see that people are thinking, well, maybe we're beginning to turn the tide. Fast forward 18 hours, the headlines read a sobering reminder that the deaths are continuing to rise. The data goes up by 7.3%. That's the actual headline. But again, in less than 24 hours, we see the next headline come out. New York reports the first decline in COVID deaths. I'm not sure how that actually is the first decline. When you look at the data, that just doesn't even logically hold, but that's the headline. Within 36 hours on April 7th, the headlines read that the virus deaths hit another new high. But then again, one day later, the headlines suggest that the virus toll shows signs of leveling off. A day later, the governor warns that the death toll could keep rising. What are we supposed to think? What are we supposed to do? And even the governor expressed incredible frustration when he was asked about this question. The press pushed him on this notion of the apex. When has New York actually reached the apex and begun to plateau? And I absolutely love this quote that the governor gave, and as a statistician myself, I can appreciate it. He says, the statisticians will not give you a straight answer on anything. At first, it was straight up, then straight down, or a total V. Or maybe it's up with a plateau and we're somewhere on the plateau. They don't know. That frustration is built around this notion of understanding variation. And when we ask, why are we in that place? I think it's a relatively straightforward answer. In these moments in time, leaders are not asking research questions. They are not. They are asking improvement questions. Now, the governor and others in his position could get many things from their statistical and research teams. They could get heat maps. They could get maps showing the geographic distribution and density of disease and death. They would get counts and rates. They could get regression coefficients. If they wanted to do statistical tests of significance, they could get p-values, and they could get complex Bayesian simulation models. But that's not what he needed, and it's not what other governors or leaders in country need. They need something more straightforward. They need an answer to the question, are things getting better? Are they getting worse? Are they staying the same? Are the changes that we're making improving things? Are they making things worse? And most importantly to the residents of any geographic area is, are we heading into the storm when it comes to death, or are we heading out of it? What does the growth phase of death look like? And one of the things that Lloyd, I, and our team have been relentless on is that for leaders that need to make decisions around containment measures, or if they're going to begin to lift the stay-at-home orders, it is crucial that they and their residents know what phase of death that they're currently experiencing. We recently published an op-ed, this was 2 days ago, outlining how governors can use this kind of science, the science of improvement, before reopening their states, because there is a lot of conversation right now in areas where the perception is that things are getting better, and we'll address that in a moment. The real issue here, however, is the things on the left, the heat maps, the regression coefficients, the p-values, the simulations, those require statistical theory. The things on the right also require statistical theory, but they require a strong dose of pragmatism, an empiricism, an integration of statistical theory with what we're seeing on the ground, which is the power of the science of improvement. we need a theory of variation, but the good news is that we've had one for almost a century. And through the work of Walter Schuhart back in the early 1930s, he introduced this notion of common and special cause variation. So the theory of variation, as he articulated it, and as many of you are aware, is intended really to do one thing, and that is to distinguish between the variation in the system that is just inherently part of the system. It's day-to-day, it impacts everyone in the system and all parts of the system. It's a signal that things are stable. That's very different from the special causes that are not part of the day-to-day system, that don't impact everyone or all parts or dimensions of the system and arise because of specific circumstances. Those circumstances allow us to maximize our learning about what's happening in real time in the data, and that is at an absolute premium right now. But Schuhart went one step further. He didn't just outline a theory of variation. He created a tool that operationalized that in practice for people, and it's the Schuhart chart, often referred to as a control chart. I think Lloyd and I are pretty consistent in our preference of calling it a learning chart, because that's what it does. It allows us to learn. This is a very simple description of a control chart, a Schuhart chart, and you can see the dimensions here. The first thing is really focusing on the subgroup of data. The subgroup could be any unit. It could be days, weeks, hours, months. It's typically an order of time. The data then gets plotted over time, and the center line is simply the average of all the data points. Those dotted lines, the upper and lower limits, are sigma limits. There are 3 sigma limits, and they're a measure of the variation that we could expect if a system is stable. Any point above or below the limit is a sign of something statistically unusual, and that's where we would want to think about asking questions, investing time and resources to learn. It clearly doesn't make sense to address every one of those random points, and it might not make sense to have a headline around every one of those data points that are random, but that's exactly what the press and the public are sort of prone and conditioned to do. Just a really quick technical point on the 3 sigma control limits. When we take the statistic that we're interested in, and it could be a count, in this case, we're looking at the number of newly reported deaths in a particular area. And if S is the statistic, the center line is just the average of that. In statistical language, the center line will be described as mu sub S, so that is basically the average of the statistic over time. It's the black center line in the previous slide. The upper and the lower control limits are simply the average of that process plus or minus 3 times the standard error. And so that's sigma sub S is the standard error. And based on the statistical distribution that we're dealing with, if it's binomial or Poisson, would determine the type of calculation needed. That's probably less important than what's on the next slide, because once that application is put in use, we want to be able to detect special causes. Where can we begin to learn? Where can we understand if things are different than they have been in the past? And many of you that have used these charts previously will recognize these 5 standard signals of special cause. The first is a single point outside the control limit, which is pretty obvious. The second is a run of 8 or more points in a row above or below the center line. And that's unusual, because if the system is just existing in a stable random state, you would expect multiple points hovering around that center line, that average point in the middle of the data. And so that the data hanging either above or below the line is unusual. And as you can see here, you can have multiple signs of special cause. We've got both a shift 8 points below the center line for rule number 2, and we've got a point outside the lower limit. The third sign of special cause are 6 consecutive points either increasing or decreasing, what we would call a trend. And the fourth is having 2 consecutive data points outside the outer limit. And then the fifth are having 15 consecutive points within 1 sigma. That's just an unusual sign. We call that hugging the center line. It's not common to have data so tightly bunched. It could be a signal that there's something wrong with the data, there's an error or whatever. special cause also can support those kinds of observations as well. I will say that the two rules that find their most common application in health and healthcare are the first two rules, single point outside the control limit and a shift or renovate above or below the center line. Those two rules are the rules that we've used in the application we're going to share with you in a moment around COVID-19 death charts. There's often a lot of conversation around why 3 sigma limits. Statisticians and mathematicians love to have this debate. The question that we often get is, why not 4 sigma or 3.5 or 2.9? And we're not sure that's the most productive conversation to have, but we do know that 3 sigma limits have a basis in statistical theory. They are calculated off of the standard error of specific distributions. Most importantly, to the earlier point around the degree of pragmatism that we need to have in moments like these, is that those limits have been proven in practice to be able to separate and distinguish between special and common causes of variation across a number of different applications, many industries, not just healthcare and health, but manufacturing, engineering, and just about any other kind of application you can think of. The third point is really important because the limits allow us to minimize the cost of trying to do 2 things at the same time that are really hard. We want to try to minimize the risk of over and underreacting. There is no analytic model that eliminates the risk to both of those things proportionately, but the control chart application allows us to find that point where we can kind of balance those risks. Relative to point number 3, and this is important because there is a lot of concern around bias, inaccuracy in COVID-19 case and death reporting. Over-reporting is clearly an issue in some areas, under-reporting in others. Having those limits in place gives the approach and the model a little bit more flex relative to those errors in the data reporting, although no model can be robust in the face of true systematic bias in the data. And again, all of those concerns, I think, loom large relative to COVID-19. The last point I'll make here, and I think this is something that doesn't get talked about enough, there is an emotional and psychological toll to looking at data go up and down when it is something as important as this. So when you think about those headlines in New York or in Lombardy or anywhere in the world, people are reacting to those. There is hope and there is panic built into how we report and think about data over time. And Deming talked about this extensively in his work. So there is, in some sense, an obligation to think about how we view variation over time relative to what it does to the individuals who have to experience this data, particularly data that's close to their home that impacts their own life and their family. One other really important point relative to Shewhart charts is that it is absolutely essential that when a system is changed fundamentally, that we have the ability to update and calculate revised centerline and limits. So you can see here, this is just a simple example. We've got baseline data. And then there's a period of instability, either through things happening, we're trying to change the system, or through things happening through no control of our own. But we get a signal that things have changed in a particular direction, ideally through an improvement effort, and then things restabilize. And the ability to be able to update the centerline and upper and lower limits is absolutely essential. We do that in the model that we're going to be sharing about in just a moment. The last thing I'll say before I hand it over to Lloyd is there are multiple types of Shewhart charts. There isn't just one type of chart, and this is a simple chart selection guide. The first and most important question is always trying to understand the type of data one is dealing with. Are we dealing with continuous variables or data, things that move forward in time? You can create intervals and ratios, or are we dealing with attribute data? For those of you that are researchers, sometimes I think about it as the difference between parametric and non-parametric data. You basically follow this flow chart and you end up often in one of 5 charts. I think Lloyd and I would agree that probably 85% of the application of Shewhart charts would be covered by one of these 5 charts. The 2 that we focused on and used to develop the approach here for COVID-19 deaths are both the C chart and the I chart, or the individuals chart. And so with that, I'll hand it over to Lloyd.
Okay, thank you, Rocco. Just follow up to Rocco's comments about we've chose to analyze COVID deaths. Now, COVID deaths has a lot of problems with it. In fact, some people say if you have a pandemic like this, we don't really know what the deaths are till months afterwards, where we go back and apply uniform definitions and so forth. But most people would analyze cases here. And we've chosen not to do cases because what we've seen is, as we've studied cases, they depend completely on the testing strategy used in a particular location or country. And in the United States, we have very different testing strategies that go across states and also over time. And so if we looked at a couple cases charts, and almost all of them are just full of special causes that reflect the changes in testing strategies. So even though deaths we have underreporting problems, we have overreporting problems, do we have to have a confirmed COVID test for a death? All that's going on. We still feel like it's the best data. And then the methodology we're using, the Shewhart chart, looking at the actual data, the variation from day to day in reporting practices is built into our analysis. And also, if we have a consistent bias, we're okay. We can still learn from it. For instance, if as we found out in New York, they weren't reporting community deaths who were not confirmed. And so, but they've been consistent about that, so they can still learn. So next slide, Rocco. So how would we start off here? Well, we're looking at a count of something that's relatively small, and that's the C chart. So that's the Shewhart for discrete counts. Center line is just the average of the counts. And the standard error is based on the Poisson distribution. So the upper limit's just the center line plus 3 times the square root of the center line, and lower limit minus. Lower limit often in the C chart will be calculated less than 0, so there's no lower limit. Here's the data for South Korea. South Korea had their first death in February 21st, February 23rd. And here's the chart, C chart that we've made for them, and it goes through April 13th, which is a couple of days ago. And here we see how they've averaged over this period 4. There's 2 periods that show special causes 8 in a run at below at the beginning, and then we had 1 period 8 in a run, but we haven't seen a major shift or change in that. So the C chart probably is doing a good modeling that. Now, these special causes are there for subject matter experts to learn from and talk about and things. So Rocco and I don't have that. We try to make the charts available to subject matter experts. But what do these special causes mean in Korea? We're not sure, but they're there and it looks pretty stable. Now let's make this same chart for Italy, advanced. Okay, and we see there's we calculate the C chart there. Here they had the first death February 23rd, and center line's 50, but almost all the data is outside of control limits. This chart, there's something going on here that this does not do. The C chart does not do a very good job of describing the variation or learning from the variation. Now we have found, next slide, there's still a lot of countries and US states that are in the mode where the C chart is appropriate. And a little later, we're going to go to the IHI site, and we can see here's 11 US states that are all still modeled here by a C chart. So these are all C charts, and we still see we have a very low Maine there on the second to the left there. We see have a center line of about 1, and they're averaging that they're having 0, 1, 2 every day, but not much more. Vermont has a little special cause. So the C chart for a bunch of these states is still useful. And we would continue to use that to monitor them until we said it's no longer useful. So next slide.
Lloyd, can I just add one thing to that when I look at this? And that is a lot of the models that are being used now just assume that every area is going to enter into a specific distribution. And so that's where like there's the statistical modeling. And then when I talk about like pragmatism and real world experience, this is what the data is showing us. And so the idea that every one of these states is going to follow into a distribution that looks like a normal curve doesn't hold out. And so I think there's something really important about that part of this being empirical and looking at data in real time.
Okay. So what about Italy, though? So the C chart didn't work for us there. We saw big special causes. So what are we going to do? Next slide. So advance that. So what actually happened is this is a signal of an epidemic outbreak. So the typical model, we have a low number of cases, and all of a sudden we get these special causes, this unexpected increase there. And so we need a control chart that can take into consideration that the system we're trying to learn from is in an epidemic environment. So next slide. So if we go to epidemiology and look at the standard epidemiological curve, and you see on the left, they have the standard indexes that they look at. And what are we going to try to model in this curve? So advance. There's two things we're going to look at. Advance one more. The first one is the onset of the growth curve. So when did we leave the C chart and actually see a signal that, hey, this location, this geography has moved into the growth page here? And then advance, the second one is, when did we reach the peak? When does it look like that we've plateaued at the top and are getting ready to head down? So what we try to do is design a chart, a set of charts that would pick up these 2 points here. When's the onset special cause on the C chart, and when can we see the peak? So next. So as we think about the how we're going to model this, we move to the I chart because we don't have a low number of deaths that can be modeled by the Poisson. In an epidemic, we expect to have deaths. So we're having counts of something we expect to see. We have one number each day, so that's an I chart. So here's our first I chart for the Italy data, and it doesn't do any better than the I chart for the the C chart. So the next thing we say, well, we've got an increase, so let's use a regression center line. So we calculate that next. Advance there. And what we're seeing is it looks okay, but we saw you see the last point's a special cause, and we're looking ahead and say, wait a minute, why is that special? And then also we have this baseline period that doesn't seem to fit. So that's our second iteration. So now let's go to our third iteration. Next slide. Hadn't advanced for me yet. Okay, so we had the first day. So our third is say, let's go with a log deaths center line. So we did the log transformation so that we can take data from different order of magnitudes. So now we see Italy here is on log death with one special cause early there. So we're saying, well, maybe we got a startup issue we have to worry about. But otherwise, it looked like it does a good job of modeling the data. And of course, the standard epidemic curve is some type of logistic function, so we're not surprised that the log function is a way to make these behave more like what we expect to see on a control chart. But we're looking at log deaths here, so it's going to be a hard time showing the public here and say, what does 1.8 mean? What does 1.5 mean? So our next step, Rocco, if you want to advance. The next step is to take that log-based control chart based on the regression line and then transform that back to the original scale. And that's where we end up with the graph we see at the bottom there. So really the data, these two graphs are identical on the top and the bottom here. The difference is just the transformation back to the scale. But now we're back to the original death scale. Now what this does, of course, is it makes it difficult to see the data early on, but it now allows us to focus on the peak and also see the curve that everybody is talking about. Next slide. Okay. When we published an article in the U.S. News back a couple weeks ago now, this is the charts that they actually used. So we showed this chart for Italy, and then we showed the one for the U.S. And so that was at the point where we introduced these charts to the public through this publication. Okay, next slide. One group that picked up on this was an organization called MD Metrics out in Seattle. And they're a group of clinicians who actually have learned to use SBC and actually have a system that is developed called MD Metrics that actually uses that. So Rocco, if you click on that link below here, and let's just go look at their website, because they've taken that model that we just showed you of the charts, the log regression charts, and actually put that, and they update those automatically each day and put some commentary around those. So this is one of the views you'd actually see on the MD Metric sites. This is a screenshot I took yesterday, and we see 20 of the states. If you go on down, you see the other states and at the different stages. So you can look at how has this played out over time over the different states there. And you see some that are low still in the C chart. Now they're not using the C chart here. They use just a run chart until we have evidence of growth, and then they kick into the a log linear regression chart there. Okay, Rocco, next slide.
Great. Thanks, Lloyd. So one of the things that we began to realize was that the outbreak was hitting states in waves. And we obviously knew this was going to be part of how the pandemic played out in the U.S. based on what was happening around the globe and other countries that were experiencing the peak of things before we did. But the two observations that we made, and I addressed this a little bit earlier, was that the states were in different phases of growth, and most, but not all, were actually progressing. And so we realized there's a really important observation here. So you can see Maine, for example, literally has been under 5 deaths per day consistently. It's a stable system. There is no sign of special cause there. Ohio is a little bit differently. It's starting to take off, and you can see the slope and the red center line looking different, and understanding how Ohio will play out over time is a really important question for leaders and anyone trying to improve or impact that. New Jersey is also in a growth phase, but the slope there is much steeper. Neither Ohio or New Jersey are signaling special cause out of exponential growth, but New York is, and we're starting to see this with some other states. So the idea that not every state was in the same phase of growth or would even progress to that point was really an important observation. And what we realized is there are basically 3 general phases to this death curve. The first phase, what we are calling the pre-growth phase, basically means that the number of deaths each day in the state are small and stable. These states have not entered exponential growth. Maine is a perfect example of that, but there are others. Phase 2 is the growth phase. So these are states where the deaths are trending higher each day. The states are in various stages of exponential growth, but they are in exponential growth. It's typically a duration of time. So Ohio, New Jersey, and other states would be in that particular phase. And then we have the phase 3 post-growth period, where the number of daily reported deaths in a state each day are flat or dropping. There's a sign that the apex has been reached, but the real sign here is that the growth is no longer exponential. New York is in that situation right now, and a couple of other states in the U.S. are there as well. This scheme or this classification is the one we shared with the governors in the United States, but it can be applied to any country, really. What phase of growth is a country in? Now, there's one really important observation here, and that is our initial approach, the one that Lloyd just outlined, the log regression approach, wasn't designed to capture pre-growth or the moment an area like a state or a country entered growth phase. And so we realized that we needed to think a little bit differently about the next iteration of the model. And what we realized was that we would have to combine 2 charts. And that's the new part of the approach here. And so what we did is integrated the science around the C chart with the log regression chart. And so if you look here, Minnesota in the U.S. Is showing its daily reported deaths. The C chart is on the bottom. Those are the blue squares. And the red arrow is indicating the point at which the C chart detects special cause. And then you can see growth begins to increase more exponentially. And so we shifted that at that moment, once we've got that signal, to the log regression chart that Lloyd described, which was the initial chart we developed. The question then is, when do you go from a C chart to a log regression chart? And we had to sort of work that out and do some testing on that based on the data that we had across the country and actually the globe. And there are three criteria. We unpack the methodology here in more detail, and we can make that available to anyone that wants it. But basically, you need at least 8 deaths to create a robust, legitimate C chart. You want to look for special cause on the C chart indicating where deaths are increasing, and then wait 5 more days before to start the log regression chart, assuming the slope is positive, which it often will be. And the reason for that is that we want enough data points to begin to fit that log regression part of the chart. And so the real innovation here is being able to detect that moment in time, again, around that day where things begin to really look different. Truly one of the most urgent signs of special cause I think I can imagine right now. And then on the next slide here, what you're looking at is basically a summary of those 3 phases. So the question that we asked is, what does if we looked at all the states and territories, and there are 55 of them in the U.S., what does that look like over time? And the blue line is just simply counting the number of states in phase 1. So these are, you see the blue line going down. That means there are fewer states that are growing slowly. That's a bad thing. We want states to be growing slowly on this. That's a sign that the containment measures are actually working. But as we would expect, as the number of states growing slowly decreases, the number of states growing rapidly is increasing. And you can see this inflection point around, I think it's around April 1st or March 31st, where we have that crossover, which makes total sense. The gray line on the bottom, you can just see that one little data point trying to get up there or lifting off the chart represents phase 3, post-growth. So these are states that have actually experienced exponential growth, signal that they are moving into the apex or the plateau and are now heading out. But the real indicator here is a marker that the growth is no longer exponential. And we want to see that number of states climb over time. Now, you can imagine doing this globally for countries. I think this would be a pretty powerful visual to understand the impact of the pandemic internationally. I won't go to the website because I know we're running a little bit low on time, but the IHI website is basically looking at all these different phases of death, and states are categorized based on the criteria that we just shared. The last thing I want to end with relatively quickly here is that we all know, every one of us on this call, as one curve ends, there's another that's about to begin. So what you're seeing here on the left is a visualization of the United States COVID-19 death curve, and this is through the Institute for Healthcare Evaluation and Measurement. And we've got, a pretty Gaussian-looking distribution. We've got deaths rising. The model predicts when that happens. It predicts the peak, the decline, and then when we'll be back to baseline. And by this estimate, it's about four months. The question my colleague Rebecca Oni and I asked at the Health Initiative is, what's on the back end of this curve for the population? When we think about food insecurity, housing, jobs, wages, we know that even right now, in some places in the United States, 70% of people that are using food banks have never used them before. And so we asked the question, what would it look like to model food security in the U.S.? And we did that, and the data we had was from the last global recession, right? A really important reference point for right now. And what you're looking at here is the percent of food insecurity in the U.S. over time. The gray bar represents the recession period. So it's the recession officially started in December of 2007. It ended in February of 2009. And what we see is this incredible spike from 2007 to 2008 relative to food insecurity. And it stays at that higher level for 6 or 7 years. We don't get back to baseline for 11 years. So we know that the pandemic that we're dealing with in terms of death and disease relative to sort of the clinical healthcare focus is urgent and needs to be addressed and flattened. But on the back end, the curves that we'll be dealing with are going to have a profound impact on the health of the populations that we're all caring about and really thinking about how do we flatten those curves. The last thing I'll end with here is that this is unemployment insurance claims data in the United States, which gets measured weekly through the Department of Labor. This is the most recent up-to-date data. We have the very first special cause signal back on March 14th. Obviously, the data is a little bit lagged, but we don't have any other data. And the question is, how is that story going to get written? What will that distribution look like? If we take a long view of time, like we did with food insecurity, will it take a decade or more for people to get back to work and to be able to generate the income and the wages that they need, which underlie health? And as Lloyd and I and the team do all of this work, I think the question that we have, and the one we're asking at the Health Initiative is how do we apply the science of improvement to the most pressing problems of our generation, and bringing all of the power, the heft, the intellectual might of this community to be able to address those questions. Thank you.
Excellent. Thank you so much, Rocco and Lloyd, for that fantastic presentation. We have lots and lots of very positive comments coming in the chat box here. Everyone has really, really enjoyed it. So yes, thank you so much. Before we move on to the Q&A, we do have the MD Metrics site on another screen here. Would you like to talk to it quickly, or will we move on in the with our time constriction?
You can put it up for just 1 minute. Yeah, I think if you will, just take 1 minute on that.
Perfect. Just one moment there, please.
So the MD Metrics site has the original charts we have of just the growth curve. On the IHI website, you see it just went up on Tuesday. We have the new charts there. So could we go down to COVID a little bit lower, the second orange box, I think says COVID projections. Okay, and then jump down a little bit, and we'll see the charts. So they're showing both the cases per day and deaths per day. So they're actually looking at cases and relating that to deaths. So they've applied this model to cases. Somebody else has suggested, could we look at hospitalizations? Could we look at intubations? And the answer is yes, we can look at all those. And if anything that's going to follow the epidemic curve there, we can certainly look at. As cases, I say, you'll see the cases chart for the U.S. is just full of special causes. And that's the nature of what I said. It's not really reliable. Just go to the bottom of this page. I just want to, so they pick out the charts that are in the high growth. We see a lot of special causes on low, a little bit higher right there. It says 50 states projected curves. The blue box, 58. Nope, that's cases. Let's go to the other one, deaths, yeah. So, and then we see each of the states there, and we can walk through. And those are updated each day, and then add a comment on that. So it's just great to see the application of Schuer's method being picked up and used in a presentation like this, making this available to every state. Okay, thank you.
Excellent, thank you, Lloyd. So we'll jump straight into the Q&A then. Our first question is, so given the number of cases can't be used because of the difference in testing strategies, and deaths is a lagging measure with 15, 17 days from time of infection, would it be better to use hospital/ICU admissions as a more real-time indicator of the behavior of the disease, the impact of prevention strategies?
Yes, I think my answer to that would be yes, where that data is not available publicly, and so we don't have access to it. But anybody that wants to see that in their local city or wherever, if they could get that data assembled, they have to get all the hospitals to cooperate. US is that hard, maybe the NHS in UK, that would be an easy thing to do. But certainly that would be a leading indicator of looking at those.
Yeah, what I'd just say too, that just the more general sort of perspective is that that question comes from someone that has clinical knowledge and experience. And so the folks that are on the front lines, I mean, are they getting the types of information and data that they need to understand what's really happening to make decisions about, capacity and choices around the physical sort of environment? And to your point around just how that data may or may not be available, it was not easy to get death data, case data, and so part of the challenge is actually getting access to the data that's needed to create these charts that can maximize our learning.
Excellent, thanks to you both. Our next question from John said, much depends on how good the death data are. Can we use variation calculations to get a sense of how good data are? Data is certainly better than for testing, but still questionable from some databases.
You know, the variation from day to day reporting, it's like deaths, they're all, like on weekends, we noticed a couple underreporting and then overreporting. That variation is going to be built right into the control limits. So that's a real advantage of the method. So we're not going to overreact to those. So that variation is built there. So I think that's an advantage of the Shewhart method, is we're not using a predetermined theory to get our variation. We're actually looking at the data to do that. So that will accommodate the variation. It doesn't accommodate the bias, certainly. And those changes in the bias would show up at special causes, a consistent bias, so we can still monitor with the charts we have.
Brian, I would just add to that too, and this is a really important question, and Lloyd and myself and the team are constantly trying to understand the data challenges. But just in terms of general sort of learning, we look at a place like Maine versus Ohio versus New York. There's just a certain level of patterns that are emerging in states that obviously the death data quality is an important consideration, but even in terms of what we can learn generally around what's happening in a particular geographic area, I think is really powerful. There's a kind of the overall gestalt of what these charts are communicating, and then there's the precision and the reliability and the validity of the individual data points, and those two things sometimes are in contrast and struggle against one another.
Excellent, thank you both. Our next question from Aryan. Wasn't it a bit strange that the UCL and LCL in the P chart were that flat?
You say P chart there. We didn't actually use a P chart. Maybe you're referring to the C chart. And the C chart, by definition, are flat. The center line for that is flat. It's not till we apply, instead of taking the average for the center line, we apply the regression that we're going to get to slanted. So almost all the basic Shewhart charts are flat center lines based on the average, and so it requires going a next step like the regression to get away from the flat line.
And Brian, I'll just add to that. I think a lot of people, when they see slanted lines on a control chart, they're like they're not used to seeing that, and so to Lloyd's point, the C charts will typically be horizontal relative to the upper and lower limits. But when we start to notice that there is clearly a particular type of trend emerging, then we can apply the same principles to the data, fit that data, get an average and upper and lower control limit, and model effectively.
Excellent, thank you. Our next question from Bayou. How are we predicting unexpected cases?
Rocco, you want to?
Yeah, what was the question around predicting specific cases, Brian? Or
sorry, the question is just how are we predicting unexpected cases? I can move on from it.
Yes, so we're not really doing that. First of all, we're not looking at cases here. We're looking at deaths. But if you were looking at cases and then special cause, unexpected case would be a special cause, and that requires subject matter knowledge to say what is this, what's going on. So it requires somebody at that geography to explain what this unexpected result is.
And Brian, I'd say that's a difference with our model compared to some of the others that are actually predicting what's actually going to happen. But the best way to make a prediction around something that's unexpected is basically the essence of what the control chart and the limits are designed to detect, as Lloyd mentioned.
Great, thank you. Our next question from Eric. Eric has asked, what is the next step for completing this analysis to account for post-growth phase? For example, you used C chart for pre-growth, log regression for growth. What about for post-growth?
Right now, we're thinking of not modeling the downward slope, but just waiting till somebody gets back into the C chart mode. And so when the initial epidemic's over, like let's say the Korea chart is this way, the C chart then will be monitoring the number of deaths as it goes down. And then we immediately have a signal for when it starts popping back up. So if we end social distancing too soon, then we're going to see, boom, that C chart's going to pop up. We're going to start another epidemic curve. And so that's our plan right now.
And I would just say on that, Lloyd, that with the C chart, we often won't get a lower control limit. So being able to detect special cause would be more geared around, are we just staying below the upper limit post-growth in the C chart phase?
Excellent. Thanks to you both. I can see Peter has his hand raised here, so we'll see if he's available to speak, if he'd like to speak. Hello, Peter.
Yeah, I just want to thank Lloyd and Rocco for this fantastic presentation. I had a question that's coming on is, Rocco, you said you spoke to the governors. Are they taking this seriously? Because over here in the UK, they debating when should they end lockdown. But if they don't use your charts that you've demonstrated, how can they predict when to end it?
Yeah, so I hope the governors read what we wrote in the U.S. News op-ed. I think the real challenge, Peter, is that the data that the governors and other leaders are basing their decisions on are based on the existing science models and tools that they have available. My concern is that without this tool becoming part of the standard armamentarium, they're just going to default back to what they know. Most of those folks guiding leaders in states and countries are not familiar with this type of approach. They're familiar with the types of approach that we talked about before, and simulations and maps and things like that. And that was the case that we made. I'm not real optimistic that they will be able to use this information to guide their decision making, and partly that's also a political sort of conversation as well.
Yeah, because I know just to say online, we have leaders from Scotland data teams and from Ireland, and I think from England as well listening in. And maybe we need a place that really looks at these SPC charts and then makes sensible decisions on it.
I couldn't agree more, and I think that I think even thinking about like how the international community thinks about leading on this and using these kinds of this approach is going to be essential. And Peter, to your point, the epidemics and the curves that are coming don't mean that this kind of thinking isn't going to be essential. In fact, I think it's going to be more important, and that's something that other countries, and including the U.S., can lead on. I think we've got a chance to have a very different conversation if we choose to do that. We've got the data and the approach here.
Just to comment on the IHI site, next week we plan on going live with countries. So we'll have charts available for all the countries. And then we're also want to finish a new template. We actually have a template available for our first generation on the API website. I typed in that anybody wants to take and use and put in their own data. And we currently are developing that template, an Excel template that people could download and use in their local site. So somebody asked about developing countries and counties and other places. We do have that coming.
And Peter, I would add the other piece to this is if you can make it easy for folks to use and apply this, they will do it. I think that folks see the value in this, and so the templates and the tools become essential. I know we've engaged a number of countries. Scotland was one of them to use this tool, and a number of others as well. So the tools make it easy to create the analyses, and then can inform the decisions that leaders are going to make. Without those tools and templates, I think it's harder.
Yeah, that's great. Thanks a lot. Because a lot of the lower middle income countries need something that they can use in an easy way too. Thanks a lot, guys. Really great talk.
Thanks, Peter.